Well, welcome everyone to Neurosurgery UCSF Community Grand Rounds for Adult Spinal Deformity. My name is Christopher Ames and direct the Spinal Deformity Service for Neurosurgery. And I'm happy to be doing this Grand Rounds with Aaron Clark, who I helped to train and is now a very busy minimally invasive adult deformity surgeon at UCSF. And also my orthopedic colleague, Vedat Deviren, who will join us shortly, who has been my partner on the complex high-risk open adult deformity service for more than 10 years. Um, Adult spinal deformity is one of the most rapidly growing areas that we're treating now in spinal surgery. And one of the reasons for that is, of course, the aging population. We just have more degenerative adult spinal deformity than we had in the past. Another is that we also have a lot of iatrogenic deformity. So patients that have had prior surgery present with deformities in adjacent segments, and they present with flat back and loss of lordosis and alignment issues related to the prior fusion. One of the issues we see in the aging population is, unfortunately, these patients have greater comorbidity. They have other issues related to frailty and sarcopenia, which we're just now appreciating much more. And unfortunately, if you look at the national literature, there's still approximately a 20% failure rate of these cases. So it remains, unlike a lot of degenerative spine surgery, really a very open and active area of research and investigation, and trying to improve the care of these patients and decrease their revision rates. Also importantly, trying to target the procedures for the patient's expectations and for what the patients want out of it. Sometimes these procedures are quite extensive, and I think Dr. Deviren will be showing some of those cases. And sometimes these cases can be managed more minimally invasively, sometimes not with a fusion of the entire Cobb angle, sometimes just with very tailored procedures, and sometimes even with a combination of procedures that are percutaneous or lateral or oblique. So I think we'll start with Dr. Clark, who's going to show us really some of the cutting edge technologies and procedures around minimally invasive treatment of adult deformity. So I'll hand it over to Aaron.
Well, thanks very much, Chris. It's really a pleasure to be here. I'm going to share my screen as I get started. And as you mentioned, I'm going to be discussing more of the minimally invasive angle for the treatment of adult spinal deformity. And I am going to focus on some newer enabling technologies, particularly around custom designed and patient-specific treatment options for these patients that do have these complex pathologies like Chris highlighted. These are my disclosures. And not to be too didactic, because I do want this to be very interactive and case-based, but I wanted to talk a little bit about my background and partly why I'm so passionate about treating these problems minimally invasively. And a lot of it comes back to a collaborative study that I did with Chris based on some of his principles regarding patient frailty and the contribution of that to spine surgery. And what I was interested in seeing how frailty applied to the frail patient population, which does apply to the aging population in many of our patients. In particular, to be focused here, I wanted to compare minimally invasive and open transforaminal lumbar interbody fusion or TLIF patients at our UCSF series here. And a lot of our UCSF spine surgeons contributed to this study. But overall, what I found can be summed up in these two graphs and looking at some patient outcome metrics, including discharge to rehab or revision surgery within 2 years. What you see is that if you compare frail patients to non-frail patients, the frail patients that underwent an open TLIF had a significantly increased risk of going to either rehab or SNF, and they also had a significantly increased rate of revision surgery within 2 years. However, if these frail or non-frail patients had a minimally invasive TLIF, it actually leveled the playing field. And so the frail patients didn't do any worse than the non-frail patients when the case was done minimally invasively, suggesting that particularly in these patients that may have medical comorbidities or frailty, minimally invasive strategies may be an important part of their fusion procedures. And this informed a lot of my treatments. I tend to gravitate towards minimally invasive treatments if possible, which I wanted to highlight with this first case. This is an 82-year-old male. He has atrial fibrillation. He's on anticoagulation, blood thinners, and that's one of several medical comorbidities that the patient has, and he would fall into the frail category. He's debilitated by severe mechanical back pain. He has a normal neurological exam. And when we look at his standing scoliosis x-rays, or an EOS film in this case, which we have at UCSF, you can see from a pulled back view that he does have degenerative scoliosis. He also has a relatively flat back, and that's reflected in a PIL mismatch of a little bit over 20. He's compensating with an elevated pelvic tilt of 23, and he's sagittally imbalanced by about 9 centimeters. He does have a little bit of coronal shift due to the scoliosis of 2 centimeters. And then looking at this neurologically, he does also have significant radicular pain. And you can see evidence that he's had some prior operations here, decompressive operations. He has very, very severe foraminal stenosis related to the lumbosacral fractional curve, with severe right L4-5 foraminal stenosis at L4-5, and he does have severe left L5-S1 foraminal stenosis at the bottom. And so the plan that I designed here was going to be minimally invasive, taking into consideration his frailty. And I did this in a two-stage operation. As Chris mentioned, the first stage was an oblique and lateral anterior operation from L2 to S1 in the left lateral position. I'll give a couple additional slides of the technique there, but particularly for the L5-S1 lateral ALIF, I work with a vascular surgeon, and I do use navigation for these procedures to minimize radiation dose. As a planned second stage, I did T10 to pelvis minimally invasive fusion with minimally invasive foraminotomies, using the tubular retractor through the areas of foraminal stenosis. I'll show some slides later about this, but I use pre-planning using robotics, which also guides screw placement. And this allows placement of patient-specific rods. This is all done through a T10 to pelvis midline incision, but a muscle-sparing sort of hybrid perk screw placement through the muscle fascia for both the screws and the rods. And this is the technique for the lateral ALIF, where you initially mark a line across L5-S1 disc space and then a vertical line from the midpoint of the L5-S1 disc. And that describes a triangle within which you place your incision. That's about 3 finger breadths anterior to the anterior superior iliac spine. And this is muscle splitting, so it is minimally invasive, which potentially leads to less hernia and in pseudo hernia. It gives you a wide exposure to the disc space with less peritoneal retraction, which possibly results in less ileus. And it allows a very nice midline placement of the cage. Now, going back to the custom or patient-specific implants, I did have a custom L5-S1 ALIF cage designed for this patient. You can see some of the measurements. It's contoured specifically to the end plate anatomy, but it also takes into consideration both the coronal and sagittal goals of the surgery, including foraminal height restoration, lordosis, and coronal correction. And this is something I've become very interested in. There are several studies that have recently come out looking at patient-specific implants. This is the first one, and Chris was actually involved in many of these, so I'll ask for his comments after I go through them. But this was looking at the ability of custom implants to achieve the pre-planned targets when looking at lordosis. And what you can see is that in the vast majority of these cases, when you look at the blue bars here, whether it's ALIF, lateral interbody fusion, or TLIF, these goals are being hit very, very closely, particularly with respect to PIL mismatch in very low amount of cases where that target is not hit. In the second study, it's looking at overall alignment within the setting of adult spinal deformity, and shows that when looking at the personalized implants compared to retrospective or prospectively collected ISSG data, that when using the custom implants, there's a significant increase in achieving the planned correction of the PIL mismatch. And just lastly, when looking at the registry study, it's looking at a subset of deformity patients within a multi-center cohort. And again, it does show that with the custom implants, we're seeing an improvement of achieving the lordotic goals, even in the very severely deformed patients. So I think, Chris, you were involved in all of these studies. What are some of your take-home points from these 3 studies?
I would say in general, we're getting much better at hitting alignment targets. Now we just have to do a better job of figuring out what alignment targets we want to hit. And however, we still are off optimal accuracy by anywhere from 5 to 20%, depending upon what study you look at. There's been improvement over the years with the utilization of custom implants, both in posterior rod space and also now in the cage space, because essentially you're controlling every aspect from a reconstruction standpoint of the realignment. So there's a Hawthorne effect, which means like because you are forced into a planning algorithm and you're forced to think about it and measure it, it's probably also going to get better. But then obviously committing to an alignment that is generated really from contouring a rod based on the realigned spine in the planning software and committing to that alignment, especially when some of the manufacturers have the ability to utilize AI to predict the reciprocal changes. It's not shocking that we're anywhere from 15 to 25% better than we are without it. And then more recently, a manufacturer has developed custom interbody devices that where we plan using the posterior custom rod, but then we also plan the anterior interbody space to be perfectly aligned for that rod. And this is especially important at the 4-to-1 segment, which has undergone a dramatic change over the years. We originally were really not realizing that in patients with both like high, low, and medium PI, it's the same. Essentially, 4-to-1 should always be around 36, 38 degrees. So the utilization of the custom interbody planning, whether it be ALIF or TLIF or OLIF, and the custom rods, especially from 4-to-1, has really improved our ability to realign patients accurately and decrease their revision rates, because so much of revision surgery in deformity is due to malalignment.
Thank you, Chris. So
I
little.
can I add
Yeah,
something
Vedat, go
there?
ahead.
So, I mean, Chris did a lot of research and work on this, which was great. What I'm observing is actually like we have all these tools to plan preoperatively, get the custom implants. I think piece is missing is intraoperative assessment. I think we need to have intraoperative assessment tools to look at the correction that we achieved, and some new adjustment needs to be done. So I think we are getting there. I think it's really important that we use the custom implants and pre-planning for much more better alignment goals.
Yeah, I think that's a great point, Vedat. It's something that Chris talks a lot about is intraoperative reconciliation, particularly in the setting of preoperative planning and custom implants. And I think it just highlights why this is such an exciting time to be part of the field as it is. It's evolving so quickly, particularly with enabling technology. This slide I included because I wanted to show some of the reasons that I really like the anterolateral minimally invasive approach for treating adult spinal deformity. In the image on the left, you can see a blunt instrument that is used to release the contralateral osteophytes that can actually be fixing the spine in the deformed position, and then placement of a cage can really help with the initial stages of the reconstruction, especially if you're doing this minimally invasively, and you have more limited posterior osteotomy options. You can see the final first stage images from an anterior and a lateral perspective, and you can get a sense from the L5S1 space of the geometry of that custom designed L5S1 A-lift cage. I get imaging between the two stages to not only get a thin cut CT for use with robotics and the pre-planning software, but also to get a sense of how close I'm coming to the correction that I want to be able to plan the second stage. And this is to Chris's other point about pre-planning the rods, using software to contour the rod to achieve the targets, taking into consideration what I'm hoping to get and what I'm planning to get from the anterior and lateral minimally invasive component. And then the two panels in the middle and the right are showing the preoperative planning of the screw placement to be able to pass that percutaneous rod to ultimately get the final correction posteriorly. And this is what it looks like in the operating room. As I mentioned earlier, it's a midline T10 to pelvis incision, but then all of the screws are placed minimally invasively through the muscle fascia. So it's a muscle preserving approach. And then ultimately the rod is passed. This is our final construct. And I think what you can see in addition to this is I really am trying with my minimally invasive deformity practice to be able to apply all of the techniques that Chris and his colleagues have shown us in the open setting as far as preventing post-operative failures. And that includes, if you can see it, the upper instrumented vertebra and the upper instrumented vertebra +1, I place cement to prevent PJK. I'm using multi-rod constructs. I'm placing screws through the SI joints to achieve an SI joint fusion. So trying to get at least the technical parts of or the technical outcomes of this to be similar to the open setting, but doing it in a less invasive approach. And in this case, some of the differences are this patient doesn't go to the ICU. He didn't need any blood transfusions. He did end up going to rehab on post-op day 7. By 6 weeks, he was off all narcotics. He was working with PT, noted very mild pain and improved mobility. And overall, I was happy with the reconstruction. But I'd love to hear your guys' thoughts on this case, Chris and Vedat.
Yeah, Aaron, it's really an excellent case, and it's when you look at the cabbage wires or the sternotomy wires, I mean, it really makes the case. This is exactly the type of patient that we're called upon to treat. This was an index procedure, meaning not really not having to revise anything. So it's very important to try to get this case exactly right. To decrease the risk this patient's going to have more surgery in the acute period or fail post-operatively. And you really balance this patient in an excellent way. I mean, it really looks to me to be nearly perfectly balanced. Let me ask you a couple questions about your construct strategy. One of the things that Vedat and I noticed over the years with interbody grafting in the upper lumbar area is sometimes you can over-lordose those patients in the upper lumbar segments when you do the interbody grafting for fusion-related reasons or to mobilize the curve in those areas. So what precautions do you take, or is it more of like a measurement on the table with adjustment via your posterior osteotomies that you how do you make sure you're not going to overlordose the upper lumbar area, which can lead to PJF?
Yeah, I think that is a really good question. And it's definitely evolved for me over the years. Whereas many years ago, I would, just like you said, I'd really try to maximize the lordotic angle of all of my interbody cages from L1 to S1. But particularly, one of the most impactful things for my practice was the mean study that you were involved in, and really thinking about focusing that and trying to achieve that 40 degrees or so of lordosis down from L4 to S1. And so I'll um, pre-plan the L5S1 cage, and then I'll plan to use a stock L45 oblique lateral cage that will hit that 40-degree mark. And then I look at the overall what my global lordotic targets are, but I'm no longer putting in hyperlordotic cages in the upper lumbar spine. And so I'm really trying to be much more mathematical with planning both 4-to-1, but also if I'm able to get up to L1, those 3 additional cages, I'm really trying to not overlordose that. And then the second one is back to your other point, is really building that into the not building in too much lordosis with the rod. And I think that has really helped um, prevent that overlordosis, like you mentioned.
Yeah, and the other thing I notice on the construct, which is a subtle point, but very important for revision prevention and satisfaction, is the fact that you have to leave a little like thoracolumbar lower thoracic curve in this patient because the most important aspect is the overall coronal balance. And the patient had 2 prior arthroplasties. If you really measure that horizontal, I mean, you're nearly right on. So hitting the balance in both planes is more critical than taking this patient all the way up to T4 and trying to get trying to correct every aspect of the curvature.
There is still some intraoperative decision making, like you had mentioned, and this I think is where robotics really becomes important because it allows us to intentionally offset screws and allow the ability of doing 3 or 4 rod constructs, and even the ability to do kickstand rod if we were to get an intraoperative long film. Back to that intraoperative reconciliation point, is using the O-arm we can get a pretty decent long film. And if the patient is still coronally off, then we have the ability to use a kickstand technique to push the patient, back more to keep them more balanced, just exactly to your point. In this case, we didn't have to do it because the patient ended up relatively well balanced, but we have that ability to fine tune it a little bit more intraoperatively, getting closer to that intraoperative um, uh, um, reconciliation goal, which I agree with Vedat, we're not quite there yet. Um,
And Aaron, let me ask you one more question,
yes, of course.
for the audience. How do you just, as somebody who trained in both like open deformity and minimally invasive surgery, how do you decide if there's a case that you just don't want to do minimally invasively that has to go to the open, for example?
I think that one of the really hard ones is, like you mentioned a few minutes ago, is the major revision surgery. If there's really a significant amount of instrumentation there and robust fusion in a malaligned fashion, those are very difficult ones to do minimally invasively. The other thing that I do often look at is the type of scoliotic curve. So Baus type C can be very difficult to get
Maybe you could
correct.
explain what that is. I think we have some non-spine surgeons in the
Yeah,
audience.
so the type C is one of the more challenging ones to get realigned in the coronal plane. It's where the patient's trunk is shifted to the side of the convexity. And what we found is that, and there have been studies that have shown this, that when doing multi-level lateral interbody, you can actually shift the patient's trunk even more off to the incorrect side. And and my hope is that if we have the ability to use a sort of a minimally invasive kickstand technique, that it can avoid that that persistent or worsening malalignment of the bow type Cs after an MIS procedure, but I think those also remain some of the really most challenging cases to do minimally invasively because of not as much control of the lumbosacral fractional curve.
That's great.
So just one more case, guys, if that's
Sure.
okay, and then I'll turn it over to Vedat. But this is a little bit of a different way of thinking about a different surgical technique. This is an 85-year-old male. He also has multiple medical comorbidities, would fall into the frail category. He has low back pain, but really, really significant left leg radicular type pain. He's had a couple of prior operations, L3-4 and L4-5 laminectomy and L2 kyphoplasty for a compression fracture, and he's even had a prior spinal cord stimulation trial that didn't work. And these are his initial measurements. So a lot of things do initially jump out. All the preoperative imaging isn't perfect, but he does have scoliosis. He has about a 30-degree PIL mismatch. A lot of it's driven by that L2 kyphosing compression fracture, but he is sagittally imbalanced and coronally imbalanced too. When looking at his MRI scan, he has very, very severe left L4-5 and L5-S1 foraminal stenosis, which explains his radicular symptoms. He has severe L4-5 recurrent stenosis after his laminectomy, and he also has some L3-4 stenosis as well, in spite of having had a laminectomy there. And so I chose a different treatment strategy for this patient after having discussions of really a more major deformity correction or a more focused fusion of the fractional curve and decompression surgery. And he, considering his age and medical comorbidities, he did want a smaller surgery. And so we elected to do a revision left L4, 5, and 5-1 minimally invasive TLIF, still using robotics, microscopy, 22 millimeter tubular retractors, and also doing a revision minimally invasive decompression at L3-4. These cases, I also use custom TLIF cages and also custom rods, even in the short segment setting like this. These are his designed TLIF cages for L4-5 and L5-S1. Again, hoping to get that foraminal reconstruction but maintenance of lordosis as well. And this shows the custom planning of the L4 to S1 rod, and also shows a little bit of additional functionality of robotics during surgery. What it allows us to do, you can see in the upper panel, is actually plan a contralateral facet fusion where percutaneously the joint is removed with a burr and packed with bone. So getting a real robust posterolateral fusion. And then again, just starting to scratch the surface using the current functionality of the robotics, but to actually pre-plan our facet cuts on the TLIF side. And so being able to do stacked cuts and actually remove the facet joint in a very, very reproducible and efficient manner is what you see in the bottom two panels. When I think about using custom rods, I think they're really, really important. It's completely changed my practice. This is kind of hot off the press, another study that Chris Ames was lead author on that was presented in abstract form, looking at custom rods to decrease mechanical complications in 200 spinal deformity patients, comparing 100 before custom implants and 100 after. These are all long segment fusions followed up for 2 years. And what you can see when looking at a variety of mechanical complications, there's a significantly decreased risk of the majority of these when looking at custom rods versus stock or versus surgeon bent rods. And this stands up to multivariate analysis. So the use of custom rods is an independent predictor of mechanical failure in adult spinal deformity patients. Any comments about this study? I think this one is really, really cool, Chris.
Yeah, thanks for referencing it and participating in it with us. This is a study that we submitted this year to the Scoliosis Research Society, so it's unpublished data, but We looked at it from a multivariate standpoint, and you can see there the results really independent predictors. Mechanical complication was, the main one by far was the use of non-custom rods. Non-custom rods had a much higher incidence of mechanical failure than custom implants. So I think in the future, if we look 5, 10 years down the line, we're really going to see a transformation in practice. It's probably still in the innovator early adopter phase now in terms of penetration into the spine surgery community, but I think it's going to be very rare to do a surgery without a custom rod, in 5 or 10 years. It's really going to shift practice because these mechanical complications prolong the recovery curve in these older, frail sarcopenic patients. And sets them back substantially. And every time they have a surgery, they have a chance for more complications. So if you can give them one surgery that has a lower risk of revision, it's really going to push surgeons into that space and using that technology. So we're hopeful. We have to see. I mean, we need to reproduce this in thousands of patients, but it seems very, very, very positive.
Thank you, Chris. Just a little bit about the setup. This is a use of the tubular retractor in a minimally invasive TLIF setting with robotics. And then the final construct where you can see the custom cages and custom rod in action. The patient, in spite of age and frailty, went home, didn't go to rehab. And he felt that his left leg had improved. Not a tremendous amount of change in the global alignment of this patient, but in his case, I was really trying to treat that radiculopathy, and it did seem to help with that. Thank you, guys.
Aaron, that's perfect. And how did you decide where to stop? You have some upper lumbar curve. When you look at that, how do you decide just to do a fractional curve only fusion? Is it based on the pain diagram? Is it based on one of the things I always think about is if I can't decide, I do what I call a foundation procedure, which is building a strong, well-aligned foundation, and then building on top of that if we need to in the future. So what considerations do you use in deciding how high to go? 3, 4, 5, 1 only?
Yeah, I think that is also a good question. I think that a lot of it is driven by, as you mentioned, the patient's distribution of pain in their leg and how that fits with their areas of foraminal stenosis. In this case, it really was, I felt L4-5 and L5-S1 contributing to an L5 and S1 radiculopathy. And then he did have that he did have central stenosis at L3-4. And so the way that I'm thinking about this, if I'm trying to be really just focused on nerve root decompression, in patients that have central and lateral recess stenosis, those are situations where I may be able to actually just do a simple decompression without a fusion like I did at L3-4. But if they have severe foraminal stenosis coming from the lumbosacral fractional curve like he had at L4-5 and L5-S1, then those are the situations where I'm really trying to get that height restoration with an interbody fusion. It's one area where I think the custom implants have really helped change my practice because I feel like by being able to plan the lordosis that I hope to achieve from L4 to S1 and also plan the foraminal height restoration that I want to achieve, I feel like by doing just a smaller, more focused fusion at the fractional curve, I still am coming fairly close to building that good foundation that you just described in case the patient does need more.
Great. Thank you so much, Aaron. Those are perfect cases to show on both ends of the spectrum with the most modern point of the spear technology. So appreciate it. Go on to my longtime partner on the complex spine service, Vedat Deviren, who's really the technical master. I think we all acknowledge, sure, our technical master. So Vedat, show us some of these horrible open cases that are so challenging.
So, do you guys see my screen presentation? All right, great.
Yes.
So today I'm going to present quite a few cases. I'm not sure if you have time enough to go through all these cases. I think I have 7 cases.
Yeah, we'll go through
Not
a
necessarily
few of them
on,
and ask questions. Yeah, sure.
sure. All right. So then if the audience wants to participate, then I'm going to ask you to give your comments and how to treat these patients. This is my disclosure. Um, And in general, like in simple, the question is like, if they are surgical, do you need to ask the question, is it flexible or not? And then if yes, then surgery becomes easy. If not, then we need to make it flexible. And how do we make it flexible, especially doing open surgeries? Like Aaron presented quite a few different techniques. We go into the front, release the disc, use the custom cages, then restore the anterior column. Or we can do some of it through the TLF and PLF approach. And then if that's not enough, then we do posterior osteotomies. We all know that there's 6 different osteotomies, type 1, type 2, type 3. Type 3 is the PSO. There is some, so when we talked about the PSO, it means that 3-column osteotomies. Type 1 and type 2 is the most commonly we use if we don't do the 3-column osteotomies, which is the releasing the facet joints. Either, you remove the inferior articular process or you remove the both of them. So these are the kind of illustrations that, commonly used for the type of osteotomies that we utilize during surgery. So the first case is the patient is like mid 60s, chronic back pain, 8 out of 10, which started with the car accident in 2019. Now he's using walker. Back pain radiates down to lateral aspect of both legs and stopped at the knee. Back pain is worse when standing, better than sitting. Back pain is worse than leg pain. He's been using walker for last 2 years. Though there's no significant myelopathy signs on this patient. So these are the X-rays. You can see that there is significant thoracic thoracolumbar kyphosis. So the PI is 50, lumbar lordosis is 18. There is significant mismatch, but I think there's also a mismatch that in the thoracic area as well. So the patient is misaligned like about 96, about 10 centimeters to the front. These are the CT scan and MRI. So this is not actually we have operated, Chris. So I think you and I are going to operate on him next week. So I want to start asking, Aaron, how would you approach this guy? So he has 2-level fracture in the thoracolumbar segment, T12 and L1, and also L5. It's kind of little complex cases, right? So we need to get the proper alignment on this patient, but this at the same time, should we go into the front, lateral approach, corpectomy? I think correction needs to be done at the thoracolumbar junction, but how do you deal with the lumbosacral junction?
Yeah, boy, I mean, I think this is a really, really tough case. I mean, I think the multi-level compression fractures are all indicative of kind of an underlying, bony problem, obviously. And so, um, figuring out how to avoid complications best can be really, really tricky here. I mean, I think that the to me, it looks like down at L5S1, in spite of having a superior end plate compression fracture, there may be the ability to at least do an ALIF at that area to get a really nice stable base to that. But he needs a long segment, I would say open um, thoracolumbar fusion to the pelvis with decompressions through all the stenotic areas um, and um, and certainly osteotomies um, through the upper lumbar, lower thoracic area to get that corrected. Because I agree with you, I think that's a significant driver of this deformity.
Chris, any comment?
Yeah, it's certainly a challenging case, and you know, one of the things that one of the things I like about the custom interbodies is that sometimes you're able to place them in segments where you would be reluctant to place a standard ALIF, for example. So because of the scalloping and because of the way that they're custom shaped to the specific topology of that end plate, they decrease the stress risers, and in patients that have prior fracture that have some sclerotic bone, potentially you can nest that on. If possible, I'd be thinking about it anterior at 4.5 and 5.1. And then because of the vacuum sign in the disc. And then this is a patient that you're going to need to go long on now, just because of the significant deformity, the osteoporosis, and the loading. The loading is a lot less in the upper thoracic than it is at the TL junction. So certainly a patient I'd be thinking about going long on. It's also a patient, if there wasn't a neurological emergency, I'd be thinking about trying to optimize, if possible, in terms of their muscular envelope, preoperative physical therapy for sarcopenia, protein supplementation, as well as osteoporotic treatment. So, but this seems like a horrible case, right? And very challenging, but this is a type of case that you and I see all the time, Vedat. This is just like a Tuesday. I mean, this is not something uncommon really at our institution.
So the question, like I agree with everything you guys both said. We plan on doing long on this patient, and then we are gonna do posterior column osteotomies through the thoracolumbar segment to correct the deformity. And but you bring a really good point how to optimize these patients. So I have questions in my mind that I don't have an answer. So if the patients have osteoporosis minus 3.5, T minus 3.5. Even if you give them the 40, or the best result with the 40 is about like, even with the studies, the average is like somewhere between 8 to 10% improvement in the bone density. And the best cases is 20%. If the T-score is minus 3.5 and giving the 40 is going to give them some improvement, but it's going to be still minus 3 point. So is there any benefit to wait for the patients when they are like, very minimal improvement with the medication to increase the bone density? So that's my question. Like, are these, medications are really helping patients and improving the patients like decreasing the postoperative complication? Or we are dealing with what we've been given to?
Yeah, you're right. I mean, we can only optimize them within a certain window, and we don't really know the threshold values of where the risk really starts to be mitigated. Those are all like very open questions. And our current practice, I think you'd agree, is to optimize them in a short-term period, um, maybe 6 weeks to 3 months, but essentially at that point we call it. And that's reflecting our current standard of care as we do a 3-month optimization,
Right.
because especially in the older patients, that's their life. Their life is a shorter window, and you're trying to improve the quality of life within, these are patients in their late 60s, 70s, 80s. You and I do them up sometimes into their upper 80s. Like, you don't have forever to wait to optimize them because they're also actively declining in terms of their physiology. So it's a complicated question.
All right, thank you. So we are doing the surgery next week, Chris. So get ready.
Perfect.
So the next patient is 75-year-old male who was here for second opinion, referred for local community surgeon. There is no loss of dexterity. Main symptoms are so these are the X-rays. You can see that there is significant degenerative flat back. Any way, like, how to assess these patients?
Aaron, what do you think?
This
This
one
is
is a
kind
little
of
bit. I'm
gynecology
throwing a
area.
little curveball on this one, so this is kind of a little bit interesting case because we show some horrible cases and all surgical.
Yeah, I think that I mean, in looking at this one, it does look, kind of on first pass, kind of similar to my first case. It's a patient, as Chris had indicated with respect to mine, it was a patient who's index surgery. I don't see evidence of at least any fusion procedures or instrumentation. And it does numerically, at least without seeing an MRI scan and CT scan, it does seem like a situation where with with multi-level interbody correction, assuming those discs are open, um, this is one that could potentially be done minimally invasively.
Yeah. So I don't want to I have more cases to share. So the reason that I'm showing this case is actually we see a lot of deformity patients, and not necessarily we just look at their images and decide on the surgeries. So I hit on some of the clinical presentation. This patient is 75-year-old. He started having low back pain in his 40s, but he's still able to play tennis without even with the back pain. Glute muscles are tight. He feel, unbalanced, like leaning forward, but he's able to hike, he's able to tennis, he's able to ski, he's able to do yard work. So given that information, we just still consider surgery on these patients despite they have significant misalignments. So in my opinion, I think, we don't operate on these patients, so they're active because I don't think that we can improve their disability is significant enough to able to do all these things that he's already been doing. So the intention to present this case is that to the audience that, we are not operating every deformity patients. So piece of the information is that patient's clinical picture, like, if they are active enough, then even though there's some disability involved with the deformities, not necessarily all these patients require surgical intervention. So the third one is 76-year-old female patient has actually interesting disease, chronic inflammatory demyelinating polyneuropathy, CIDP, and patient here again for a second opinion, low back pain, radiating lateral left thigh, but stops at the knee. Pain is worse prolonged sitting, better with standing. And it's been going on, like decreasing your function in the last 3 years. Patient had gradual progressive loss of dexterity, drop of items, clumsiness, no balance issues, no saddle numbness, no bowel and bladder incontinence. So this is the X-ray. All right, so I'm gonna ask the questions on this one. Again, another patient. So if you look at the again patients, like, the daily living activities, so she can hike up to 46 miles. She can complete all of her, daily living activities with minimal pain. I think her worsening dexterity and dropping items is related to CIDP. And when the patients can hike like 46 miles comfortably, despite there's like, if you look at the x-rays, there's a horrendous deformities. And I decided not to offer surgery on this patient. So this patient, I don't think that we can really improve the quality of life more than she's having already, because she's going to need the long fusion, front and back. I think we need to minimize the risk for these patients by not operating. So I just wanted to show the audience that, we see all these deformity patients, but not necessarily all of them undergo surgeries. We look at their clinical presentation as well.
Could I ask you one
Yeah.
question on that? If you go back just to the
X-ray?
image, yeah, for a second. One of the issues though in this patient, which I'm sure you discussed with her, is that she's off balance, and when she's so off balance and she's aging, there's going to be a certain point where if she becomes symptomatic, she's going to be too old, too frail, or her complication rate's going to be too high to offer surgery. Is there any consideration in that case where you would say, well, maybe you're not the ideal candidate now because your disability is too low, and your level of function is too high, but if you're 5 years down the line and then you have a cardiac comorbidity, your bone density is worse, and it's likely that this patient's coronal imbalance is going to progress. I mean, she's nearly like rib on hip, that you're going to need surgery when the complication rates are going to be even higher. So maybe you should think about it sooner. How do you think about that in this case?
I totally agree. So I tell the patients, like, you are quite active now. I think I'm going to follow these patients. Depends on how much declining that she's going to show over time. And I think you're absolutely right. With the aging, we know that the risk and complication increases. Don't ask me not why, but my cutoff is like somewhere between 85 years old. I think after 85, they, really having difficult time to recover the surgeries. But you and I operate on a lot of patients, like, late 70s, somewhere between 79, 81, 82, and they do tolerate well to the surgeries. Um, I'm not sure exactly where the cutoff is. I think it's more like how healthy they are. And this patient is quite healthy. There's no other medical issues besides, his neurologic, syndromic disease. But I agree. Eventually, this patient probably is going to be disabled enough that require surgeries. But I don't know how to decide on like, when to do the surgeries and where is the like, the cutoff point. Like, okay, so we don't want to do wait too long for your surgeries. I at this point I more look at their like daily living activities if they are active and tolerating like normal life, and especially like somebody's hiking 46 miles a day. I don't even hike 46 miles a day. I'm not sure if you do, Chris. So I think it's really important that their walking abilities and standing and walking. That's the critical criteria for me to decide on surgery on them. But in terms of age, I think my cutoff is if somebody is getting closer to the 85, I tell them like, it's going to be really hard for you to be a good candidate after 85.
Chris, just to kick the question back to you also, I mean, you've done a tremendous amount of work on predictive analytics for predicting outcome after surgery, but do you see in the future an area for actually being able to look in the preoperative setting? What are the likelihood that you progress, looking at, all the different metrics that you guys are collecting, that this curve does progress and the patient does develop significant disability in the next 5 to 10 years? Do you think that's on the horizon?
Yeah, for sure. That's on the horizon. That's going to involve tracking a lot of non-operative patients, which is much more difficult outside of a data harvesting methodology that really sits within the Epic or other hospital records. It's much harder to do in study group registries or even in industry registries, which don't have a lot of non-operative patients. Because right now, without saying this is a non-operative patient, you would need to track the patient's quality of life over many, many years to then be able to predict what that quality of life would be for a similar curve with and without a given intervention at a current biological age, at a current rate of aging, at a current, gait function, current bone density. Um, it's coming for sure, but it's the non-operative tracking, which is a challenge right now from a data standpoint. Um, but there are, startups in the space that can go in and harvest, raw data and imaging data, and we may be able to answer that question, in probably 5 to 10 year time horizon.
All right, so the next case is 81-year-old female who has back pain, bilateral numbness, weakness. She had prior surgeries in India, and then immediately after the surgery, the patient starts feeling imbalanced and continue. She's also continued to have the right leg weakness. There's no sign of infection. These are the preoperative X-rays. It's not uncommon that we see similar images, like Chris. So I'm just gonna go through these cases. Like if you look at it, there's significant like sagittal imbalance. And we obtain advanced images. You can see that the construct selection is absolutely like inadequate to support the surgeries. So they didn't put enough pelvic fixation. Of course, that the screws pulled out and loosen up, and then patient become really imbalanced. And there's also no anterior column support. So over time, we recognize that it's really, really important to give the anterior column support and also do good enough pelvic fixation. Like Aaron showed, like 4 iliac screws is actually quite standard in our practice right now. So the patient, of course, like these type of surgeries are going to fail. So we've seen, despite these surgeries being done outside the country, but we've seen this similar construct in our community as well, that the patient only undergo like posterior instrumentation without enough pelvic fixation, and they end up failing in a couple of years and then requiring additional surgeries. One of the key for successful surgery, we talked over and over this during this conversation, that the prep planning is really, really important, and selecting the custom implants or custom rods are really important to achieve more predictable, reliable result on this patient. So what we did is, we did L3 PSO on this patient and did multiple pelvic fixation. You can clearly see that the patients can be really successful alignment, achieve successful alignment goals with preoperative planning and custom implants. So these are the post-op images, and patient did quite well after the surgeries, and she's able to ambulate without, using the walker. So the next patient is another actually similar like revision surgeries that we performed. 66-year-old male patient, severe back pain, patient had multiple prior surgeries. And then for the time's sake, I'm just gonna go, a little bit quick. So this is actually like, being done in our local community. You can see that the surgeon is like talented surgeon. Like he did all these like, proper placement of the screws. Like, he used multiple pelvic fixation. But the one thing that I think you can clearly recognize that there is no preoperative planning to achieve the alignment goal. So just putting the screws in the right places and choosing good pelvic fixation not necessarily means that good surgeries. You need to make sure that you achieve the alignment goals. So you can see that clearly patients had a significant flat back, and of course he cannot, stand up straight. Not only so that the rod's actually distally being failed and fractured. So these are the CT scan. You can see all the screws are being properly placed. And then we did the L4 PSO on this patient to achieve the alignment goals. Patient did really well after the surgeries. We didn't even replace the pelvic fixation. We used the same pelvic fixation that originally being used during the index procedure. But however, you can see it on the right side images. Again, we are going to reoperate on this patient soon. Patient, despite the multiple rods and multiple iliac fixation, broke the rods distally, right above the iliac screws. What do you think about Aaron? Like, why this happened despite like, we have 7 rods on this patient, and we rarely see the multiple rod fractures with these type of constructs. Any
Yeah, I
comments?
mean, honestly, I'm not sure. I mean, all numerically, like everything looks good. I feel like the location of the osteotomy was absolutely appropriate. It, I don't have a great explanation
I
for
mean,
this.
I have more images too. Like even if you look at it, the CT scan, patient is actually fused anteriorly and posteriorly. I think rarely we see in these patients. I don't have the SI joints, but I think some of these patients actually quite mobile in their SI joints. And we had 1 or 2 patients with Chris that the wide SI joints and flexible SI joints. I think in some of the cases that I'm not sure how to evaluate to do, preoperatively planning the SI joint fusion on this patient. I think this patient we are going to revise the route because patient is slowly leaning forward, and I think he's quite mobile on the SI joints that we need to fuse the SI joints.
I would just make one
Yeah.
additional or two additional comments on the rod fracture. We've done an amazing job. I mean, a lot of it, to be honest, Vedat, like you and I deserve the credit for in terms of a lot of the multiple rod constructs and really nearly eliminating rod fracture nearly as a major problem in adult deformity surgery, where it used to be over 20%. However, there are two things that we really can't control for that you didn't mention beyond the mobility in the SI joint. And one is the patient's bone density. So patients that have low fusion mass density transfer a lot more of the stress and strain to the hardware. And that's something that, it's very different in older patients that have low bone density. And some of it's not just what we get on DEXA, for example, but probably much more complicated calculus of what's the pelvic bone density, the spine bone density in terms of Hounsfield units or quantitative CT. The other issue is truncal eccentricity on walking. It's something we don't measure, but it's how much dynamic loading the patients undergo as they move around. And there's some patients that have a tremendous amount of trunk sway and a lot of eccentricity. This is research that we're doing in combination with Jeannie Bailey's lab at UCSF, looking at what she calls the K-score, which is how much kinetic truncal eccentricity patients have as they walk. Someone that's really bending forward and shifting a lot is someone that's obviously going to have a much higher rate of rod fracture. So, Vedat, I think it's 8 o'clock. Those were
I know.
incredible cases. And just want to thank everyone for participating. Thank you for your trust in UCSF Neurosurgery and Orthopedics. We thank you very much for trusting us with your patients. Have a good day.
Thank you for including me, Chris.
Thanks, everybody.
All
Thanks,
right,
guys.
bye.